The next speaker is Professor Cherrie, and just thinking about the hierarchy of control, we talked about assessing, doing this risk assessment, the primary prevention piece, looking at the legislation, and now looking at more engineering controls around more localized ventilation. I'm going to pass you on to John Cherrie now. So thank you, John.
Great, thank you, Kevin. I hope you can see my screen.
Yes, we can.
I've got two screens, so it's a bit confusing sometimes, even for me. I'm an occupational hygienist, and I'm based in Scotland in the UK. We have just begun a project which has been funded by the Scottish Government to look at novel methods of controlling SARS CoV-2 in health and social care settings. And our project is really at a very early stage, but one of the things that we've become very interested in is looking at novel ventilation systems for controlling the virus, particularly looking at ventilated headboards and control measures for dentistry. And so I'm going to talk a little bit about those two areas. It's really still very early for our project. We haven't really got any results ourselves, but I really want to summarize where we're coming from, what we're trying to do, and what the available evidence is telling us. So, so we, in an ideal world in occupational hygiene, we would like to have some understanding of what the exposure of the people, the workers, is. And what sort of safe level or occupational exposure limit that we want to try and achieve. And then we can apply some sort of controls to reduce the exposures to below that occupational exposure limit. However, notwithstanding Lisa Brosso's very interesting talk that introduced this session today, we really don't have much idea of what the exposure of workers is to this virus. We don't really know what a safe level is, and we don't really know how effective the control measures that we might be selecting are. And particularly in terms of the control measures, the fact that we have multiple routes of exposure, that we may have aerosol exposures, we may have droplet exposure, and we may have fomite exposure as well. So there are these multiple routes, and the effectiveness of control measures in any particular situation will be dependent on the relative importance of these different routes. So, from my perspective, I think all of this bodes that we should really take a precautionary approach when recommending control measures. And that's really, I think, where we're coming from. Now, in the UK, we have regulations which are quite general and generic, and they cover all hazardous substances, and for hazardous substances, it does include the coronavirus exposures that occur in workplaces. And we have, to some extent, discarded this idea of control hierarchy in favor of what we've termed good control practice. But there's still a hierarchy because we still mandate that the first obligation of employers is really to either eliminate or substitute the hazardous agent, and the final choice that employers should make is to use personal protective equipment. But everything else within that, we really expect the employer to choose a mix of control measures that gives the best, the most effective and reliable control solution in that particular situation. So that might be using localized ventilation along with personal protective equipment for some aspects of the work, and may be a good sort of combined effort. But really personal protective equipment should only be used where it's not possible to control the exposure adequately by other means. So given that that's the obligation on employers, why are we not seeing more use of local ventilation in controlling this virus? And it's not for want of there being solutions out there, because in many instances, the solutions that we've developed for general and industrial uses can be translated into healthcare settings. And there are other solutions that have been developed over the years as we've tackled various outbreaks of infectious disease. And one good example, I think, are these ventilated headboards that were developed by NIOSH. And they put a lot of effort into trying to validate and ensure that they were appropriate. Just so you understand a little bit about it, that's basically an arrangement where the bed is partially enclosed by a shroud, and that this is then air is extracted through the enclosure into a HEPA filtered system. In essence, it's really a sort of adaptation of a fume cupboard type arrangement that you might expect to see in a laboratory. So NIOSH developed this system and then tested it out using a computational fluid dynamics setup, where they simulated patients coughing and tested for a variety of scenarios. Baseline scenario where there was no controls, and then everything up to a full system operating with the HEPA ventilation. And you can see on the chart here that over time the simulation shows that for case 1, which is the blue line, the concentration slowly drops, but for case 3, which is the fully ventilated headboard, that the concentration from a single cough drops almost to nothing by well, just around about 20 seconds is what the researchers claim. NIOSH went on and further developed further tested the system in practice and found that the measurements of the containment obtained was very similar to what they'd identified in the computational fluid dynamics test. So really, there's a reasonably good case for expecting that this kind of system would be effective. But I don't know about you, but I've never seen one of these in action. And so there must be something that's giving rise to the system not being applied. Sorry, I've just gone too far. I'm going to, yeah. And that's really, it stimulated a group of clinicians and engineers and occupational hygienists in Scotland to really try to address this and find out what is the barrier that's stopping these systems being introduced in practice into hospitals and care homes. The consortium is really an output of the pandemic, because a lot of the clinicians and engineers involved in this are really unable to do anything else because they're either furloughed or they're just unable to get work. And so it's a great way for all of us to apply our knowledge and energy to try and do something positive in this situation. You can see in the photographs mock-up of some of the NIOSH systems, and the first thing that certainly strikes you is that it looks very much like a do-it-yourself setup. And in fact, actually, when you look on the NIOSH website, they give you do-it-yourself instructions for constructing their system. And I think this is one of the reasons why it's not been widely adopted, because there isn't a proprietary commercial system that is really developed to do this. The other problem, which you can see from the ventilation ducting on the far right photograph, is that it's not really something that's very easy to retrofit into a hospital. Might work quite well for a new field hospital, but certainly not going to work in a conventional setting. And so there are certain barriers to implementing this. And I think the other things that we've identified is that you need to have a a quiet and acceptable environment for the patient and the staff to work within. You need to think about access for staff. And in many medical procedures in intensive care, the staff member needs to have almost 360-degree access to the patient. And the kind of setup here just doesn't facilitate that. And you need to have a system that can be safely cleaned and maintained. And again, these systems don't really give that sort of impression. So I think the overall feeling is that we are moving towards something which is much more commercial product that could be retrofitted into hospitals and provide a good alternative for hospital managers. That project is underway, and I'm sorry I can't tell you much more about it just now, but we are really progressing it quite well. The other area that we are interested in developing solutions for in dental surgeries. In the UK, and I guess in most parts of the world, dental operations have been paused and are starting to be reintroduced. And there's been many reviews of the types of controls that are needed to restart this type of operation. I think almost without exception, the ones I've read don't even mention local ventilation. They provide everything else. So, things upstream like testing the patient, how the patient should interact in the waiting area, right through to the use of personal protective equipment. But there's this big gap in the middle, which is the use of local ventilation to try and reduce the exposure. Just by way of hierarchy of controls, I think two of the suggested recommendations are quite interesting, and the photograph shows one of these, which is a rubber dam, which is essentially a barrier between the mucus in the mouth and the tooth that's being operated on. And I haven't yet been able to find any research that looks at the effectiveness of these types of systems in terms of reducing aerosol generation or droplet emissions from the procedure. But I think that seems to be a very promising additional source control that's worth looking at. There's a very recent paper which shows really the problem that dentists face, which is looking at the emission of droplets from dental operations. And in this situation, they carried out simulated operations with a mannequin using fluorescent dye in the liquid that was in the scaling tool that was being used. And they used a matrix of papers laid out in the dental surgery to collect droplet deposition, and then they analyzed these under UV light photographically to determine the area of contamination on each and the intensity of the contamination. And the four Windows type diagrams show the results for three of the conditions that they looked at. One where the dentist is using the tool but has no suction. The second where the dentist is using the tool and this time there is this suction to remove the fluids from the patient's mouth and remove some of the air in the mouth as well. And then the final is the same operation, but this time with an assistant holding the suction tube. And you can see in all three of the diagrams that there's quite considerable spread of the contamination outwards from the patient out to about 1.5 meters, and that regardless of what type of suction was used and how it was done, there is fairly extensive contamination. But if you look at the quantitative data they have, you can see that with the suction, you get about a 75% reduction in the area contaminated at 0.5 meter. That's the average over all the 0.5 meter samples that were collected, and about an 85% reduction when the assistant was doing the work. The researchers couldn't quite explain why the assistant made that additional benefit, but they, I think it was speculated that it may be because of more careful use of the suction. Of course, there are lots of proprietary ventilation systems available, sold for dental surgeries, and here are just a small selection of the ones that you can find on the internet. And they're all basically the same type of design, and those of you who have seen welding operations will recognize the similarity in the design of these systems with ventilation for welding fume. The movable arm can be located close-ish to the patient, but to really have much effect, it does need to be really quite close to the patient. And well, we know from other research that this kind of ventilation system is not terribly effective. These are data from a review carried out in 2008, looking at the efficacy of a variety of different local and other types of control. And you can see that for local exhaust ventilation with an enclosure, the median efficacy is around about well, it's almost 90%, and the 25th to 75th percentiles range from around about 65 up to almost 90%. And for integrated ventilation, local exhaust ventilation, similar sort of picture. But when you come to look at mobile LEV, like the flexible arms that we saw in the previous slide, then the efficacy is much less, and typically is only around about 50%. And that's primarily because it relies on a lot of diligence on the part of the operator to position the entry to the ventilation appropriately. We have just submitted a research proposal to test the efficacy of these systems, but I think what we really need to do is think about improving the entry for these kind of devices. And although this isn't really dentistry, these are taken from a study looking at intubation of patients where the work was done on dummies. But you can see on each of the photographs, there's a mask type device, which is either located in the forehead on the left-hand side on the center diagrams, or on the chin on the right-hand photograph. And the researchers looked at the effectiveness of their system by measuring the aerosol concentration in the vicinity of the process through some sort of simulated coughing process. And you can see that the red line, which is the situation with no ventilation control, the concentrations are much higher than when the device is placed on the forehead, and very much higher than when it's in the chin position. And in fact, in the forehead, the device has about an 85% efficacy, and on the chin is probably in excess of 99% effective. And I think that's the key here. We need to work towards developing new and innovative ventilation for the kinds of procedures that are being undertaken, that can position the entry to the ventilation as close as possible to the source, and to make it as reliable in terms of containment as possible. And the reason that the chin system works so well, as you can see from the photograph, is that it actually partly covers the mouth, and so partly covers the source of the contamination. So I think efficacy is really very important to understand, and it's not something that's really very well assessed. And in our study, we're trying to assess the efficacy in terms of reducing aerosol concentrations, which we plan to do using a surrogate aerosol. just in the same way as that NIOSH did with the ventilated headboards. And we want to look at the reduction in contamination around the source using fluorescent tracers, much the same as we had for the dental study. And then we want to integrate these two types of measure in the kind of models that Lisa has been describing earlier today, to try and assess the overall impact of the control measure on worker exposure. And then finally, these systems need to be tested in real life to assess their efficacy. And it's well known that efficacy estimated in controlled laboratory conditions is generally very much greater than that which you would find in real life practice. So to finish then, I think source controls are an important omission in almost everything that people are doing around SARS-CoV-2 control. Most people just seem to jump from upstream to personal protective equipment without even thinking about what might be done in between. And that's a major omission. And I hope that one of the things that we can see as an outcome of this pandemic is a greater focus on practical control systems in the future. These systems exist, but they're generally not used, mostly not fully validated, and certainly not exactly designed to be the most effective that they could be. What we really need are systems that are off the shelf, that can be purchased by healthcare providers, and that these systems are endorsed as part of routine clinical care. Well, thank you very much. I hope that was interesting for you.
Thank you very much, Professor Cherrie. That was the information was really great that you shared with us. I decided to let it go on a little bit because, the value in this session is all this amazing information that's being shared, and there's a lot of questions in the chat box that we can sort of address later on when we go. So I just wanted to make 2 points here. It's really important that, as these controls are put in, that they're evaluated for the effectiveness, the efficacy. And I just also want to ask everyone on the call, on the webinar, if they have any examples of, success stories with some of these innovations and technologies being provided, please share it with us and we can sort of present it back in future webinars.